Okay, so this time, the panel, we've got rid of David Bowdler. So we're now good cop, good cop. No bad cops today. Okay. Okay, so the first thing we're just going to give a few of you opportunities for each question, but we'd just like to ask the panel, how do they approach the ear and why? So we'll start off with Professor Grolman from Utrecht, who's a very famous Stapes surgeon.
I always approach an ear very carefully.
Yeah, do you sort of creep up from behind?
Mostly endural general anesthesia.
So just explain why, because for those of us who use the superior peroral approach, we don't quite understand this idea of cutting the patient's ear.
It's a very rapid technique. I suppose one of the negative sides to it is that you make it some additional bleeding because you make a bigger wound bed. It does give you more exposure, and I do have all the apparatus to do it peroral. I'm just used to do endural. I like it when you need to harvest some vein or something, or not a vein, but
soft
tissue.
Some sort of
it helps.
Okay, Doug, what about Seattle?
I approach the ear recklessly. No, I'm kidding. Very carefully, and I am actually a per-oral person, and I do my Stapes about probably 95 to 98% under a local anesthetic with mild sedation, with the patient controlling their own airway. And the reason I do that is the per-oral, I think, is a quick operation without an external incision and really no risk of stenosis of the ear canal postoperatively. And by keeping them awake, I've actually had 2 cases just since January where what I'll do is I'll complete the operation, lay the drum down, and then I'll actually whisper to them, talk to them. And I've had 2 patients tell me that they actually had vertigo, so I just lifted the drum, put in a shorter prosthesis, and they did fine. So it seems to work well.
And do you measure routinely?
What's that?
Do you measure your prosthesis?
So, I got a great piece of advice from Howard House when he was alive, and he said he measured every one of his, 24,000 cases and put in a 4.25 prosthesis. So I measure ones that look unusual and don't measure all of them.
Okay. Franco?
Always 100% endural.
Endural,
because it's a larger approach, because I can also get some connective tissue in the incision, fish technique, and always 100% local anesthesia.
Okay.
I do all mine per oral. I offer local anesthesia, but most of my patients and myself prepare general with laryngeal mask when I do general.
Okay. Yeah, we'll just go around just so we know what we're all dealing with here.
I do a small endural releasing incision. It does give you more exposure in the speculum, and because you have a lot of residents and trainees, and just easier for them. And I do them in a general because we have different nurses every time we operate, and I'm just tired of explaining to an awake patient what I'm looking for.
And you use a speculum. So when you use your endural incision, Franco, do you use a speculum as well, or not?
Yeah,
no speculum. No speculum.
I don't use a speculum.
You don't, sorry.
I says it's wider than a speculum in my experience. You get better exposure.
But do you not think that the narrow bit's the bone, isn't it? The bone that's the...
Well, actually, I've tried both. So I've done the speculum with the speculum holder. I did that for a few years. Then I just found our trainees they were easier for them to do with the endural. Then I switched to endural.
Yeah. Okay.
I do it peroral, general anesthesia in 95% of the cases, use a speculum holder, and it's, I think, faster, yes, and quicker, and I don't see the point why to make an extra incision.
Yeah. Transcanal, peroral, the narrowest part of the canal is just lateral to the tympanic ring, so I can't see any benefit to endural, and the speculum compresses the skin and stops bleeding.
Yeah. So what you find with Stapes surgery is people tend to do what they were taught to do. So, if you're chief, if you're in a lot of Europeans use endural, and they've been taught to do it, and that's what they do. But it's very interesting, and I think people are quite reluctant to change, which is, we're quite keen on many things, but we find that the trainees may find it more difficult, but really with a bit of encouragement, they can do remarkable things.
She's never going to get in there. Aye.
So our trainees can get into difficult places easily. So this is the Yassergill speculum holder, and although John can't use it because this, we've got the pointer? Yeah. This here gets stuck on his tummy. Most of us can use it. And this is very nice because you can just move it a little bit. But as they were saying, if you use a speculum, it has the advantage that it can allow you stability. And we know that in ear surgery, stability is pretty key for us, as you'll see here. Okay. All right. So now we're going to go back to our panel and ask them about their indications for surgery. Just straightforward, as a rule of thumb, how big is your air-bone gap going to be for you to be comfortable to offer surgery? John, start off.
Yeah, I like 20.
20
20
decibels?
dB averaged, yeah.
Anyone differ from that dramatically?
I agree.
About 20 decibels. Okay. There we go. Easy. And do you do speech recognition scores before surgery? Do you do that in everybody?
We used to do that, but we don't find it very useful.
Don't do it anymore.
No.
Anybody do it routinely?
Yeah, I do it on everybody, but I'm now considering whether I should continue.
Yeah, okay. So generally if they've got good bone conduction, they tend to have good speech, but I think maybe reserve it for when their bone's poor. What do you reckon, Manohar?
I'm sorry, I just put my head on because we do it routinely in North America. It's done routinely with every audiogram. But it is, you have to be careful with the speech discrimination score. If your air curve is about 80 or 90, you have to make sure that they present a high enough level to measure it. So if your air curve's at 80 or something, and your bone curve's at 50, and then they measure, and they only presented at a 90, then you can measure speech discrimination that seems low because you haven't presented enough above sensation levels. You can be misled by that.
Why do you do it? Do you have a threshold where you say, actually, this patient's not going to do well?
No, it's just, in North America, it's pretty routine. In every audiogram, they get speech discrimination. Everybody gets it.
Yeah. But that's quite labor-intensive, isn't it? It takes a while to do that. Do you do this in Beirut as well? Do you speak on everybody?
It's routine. Just our audiologists are trained in America, so whenever you ask
routine,
for an audiogram,
but is it
speech.
any use whatsoever?
I can't say that.
I want to know what
I can't say that it's ever changed my management, but it's something that we routinely.
So you've done it routine, and it's never changed your management. Okay. Okay. But the question then is, how poor does the score have to be? Because if we say 2/3 for it to be poor. Okay. Anybody anything to offer on this?
Yeah, I think if you see an asymmetric speech discrimination score, it's entirely possible to have an acoustic neuroma and a conductive hearing loss from an otosclerosis in the same ear. Daryl Brackman used to show slides of cases he got burned on. And keep in mind, when I'm doing an audiogram, my attitude is I'm evaluating a hearing loss.
Yes.
And I'm not evaluating for otosclerosis. And the other indication, I wouldn't operate anybody who didn't flip a 512 tuning fork.
Yeah. Okay. So tuning forks. Do you use tuning forks?
On all patients.
Yeah. I mean, I think tuning forks really, really important. Okay, we're going to go on to our next.
John, not you again, please.
Their better hearing ear, or do you want to see a speech discrimination?
I mean, my personal feeling on speech discrimination, if they've got normal bone conduction, I'm not particularly interested in it because the chance of them having poor speech discrimination is very limited. And even if they've got an acoustic neuroma, if they've got otosclerosis, I'm happy to do their operation.
So you ask them which is their worst ear?
But they're likely, so, but I think if the bone conduction's down, then I would like to see a speech discrimination score because my personal experience, if they have a poor score below around about 60%, they get better hearing, but they're usually not that happy with it. So I would be really cautious about operating on them.
Can I ask you, I've never understood this tuning fork thing. If you trust your audiologist...
I don't.
Okay. Well, so maybe that's the reason.
I use a tuning fork test. Hello. If I'm using a tuning fork and it's negative, and my audiologist says it's not a conductive hearing loss, I send them back. And I trust I really trust the tuning forks.
Chris, would you use just a C2, or would you go C1, C2, and C3
I
negative?
do C1, C2, C3.
So all three negative before you operate?
C0, so 256, 512, 1024. And I like the lower two to be negative. I know with the 1024 it's often not. Okay. But if it is, I'm very happy, but it's often not.
Well, the test-retest in tuning forks is about 20%.
Yeah,
So
I really don't believe that. I don't believe that. I know George Browning says that. Don't believe it.
Yeah.
I think that retesting the patient 6 months later or a few months later is not blindly, well, not knowing the previous result of the audiometry is sometimes helpful. Sometimes if the audiometrist is not very experienced, you can sometimes have surprises.
Yeah.
So I must say
Repeating the audiogram is...
I must say that my practice, I get a lot of patients who come in referred with an audiogram. And audiogram always goes to the tuning fork. If there's discrepancy, we repeat the audiogram. And I had a patient just 2 weeks ago who came in with an audiogram that looked like a conductive hearing loss. Tuning forks didn't match, and that patient had a dead ear and was getting a shadow curve. So if I do a stapedotomy on that patient, it's now my dead ear and my complication when the ear came in dead on the front side. And keep in mind that superior semicircular canal dehiscence was discovered by Lloyd Minor, and I was his fellow and did the first case. And the way we discovered that was a persistent conductive hearing loss after a stapedotomy. And we CT scanned him to look at the ossicular prosthesis to make sure it was in the right place and noticed that the cap was missing on the superior canal. And then that started the investigation. So I will not do a stapedotomy without acoustic reflexes. Because if the acoustic reflexes are normal in light of a conductive hearing loss, even with normal bone thresholds, they get a CT scan before they go to stapedotomy. Now, you can avoid that if you CT scan everybody. And I would argue that it's more expensive to do a CT scan than acoustic reflexes.
It's funny that you say that, because we looked at all our failures, and that's a huge amount, obviously, and but also revisions, of course, and we also always do standard CT scan on revision surgery. And none of them had any dehiscence.
Well, I have to...
One would expect a higher incidence. Eh?
I have to fess up here. I have a patient where I operate on the patient, no benefit whatsoever. I was absolutely sure the surgery had gone fine. Did a CT post-op, barn door superior semicircular canal dehiscence. And I think if you go into the ear and you think it's, some of these foot plates, it's very obviously mobile, some it's very obviously fixed, but there are a few, it's not so obvious. You divide the joint, the rest of the chain's clear. I'm sure I made a mistake there. And so I think, people have made mistakes like this. So I think we scan them now since then, actually.
I've seen two patients who've had both. I've actually explored, they've got a superior canal dehiscence on the CT scan, and they've had a fixed foot plate, completely fixed when you palpated it. So I'm not sure that necessarily that if you see a superior canal dehiscence, it doesn't exclude
maybe.
sclerosis.
But he didn't get much better with his surgery.
No. Well, cone beam CT is a very good way because the resolution is 0.125 millimeters, so the chance to... The vamp is what you should do, of course, to make sure... I use the microphone.
I think it's... but again, were the acoustic reflexes normal, or were they abnormal on your superior canal dehiscence with otosclerosis?
Well, this actually was a failure from a previous stapedotomy, so they did a CT scan afterwards. But we went back and palpated the foot plate; it was completely fixed. So so in both those cases, so we replaced the piston. In fact, didn't do anything with the superior canal and close the gap. So. And
just remember, you can have an enlarged vestibular aqueduct, a posterior semicircular canal fistula, or and perhaps there is some theory that even a patent cochlear aqueduct can give you a conductive hearing loss, and the tip-off is normal acoustic reflexes and low-frequency, supernormal sensory thresholds. So if you've got a threshold above 0, that may be a tip-off. So that's when I would investigate further, and that's when a vent comes into the evaluation, and it becomes much more of a gestalt evaluation to get there.
Associated pathology is not so uncommon. I've been surprised to see cases with otosclerosis, superior semicircular canal dehiscence. And we had one patient, a lady, I never will forget her, she had superior canal dehiscence, otosclerosis, an acoustic neuroma on one side, and a meningioma on the opposite side. And what did I do? No, hearing aid.
Let's just move on, otherwise we're going to get tied down, and it's a good discussion. But let's just quickly hear from the panel, absolute contraindications to surgery. John, we'll start with you. What would be your absolute contraindication?
Well, otitis externa is a contraindication, and this is Aspergillus niger, isn't it?
Yep.
So I'd want 3 to 4 months free of any problems before I would even consider going into that ear.
And if they've just had a recent otitis externa,
I'd still want a couple
3 to 4 months.
I'd want several months, absolutely certain. Yeah, this is an operation. This is a cold operation. There's no hurry. They've waited 10 years. Some of them. Why not wait another 2 or 3 months? No hurry. Patient's more important than doing the operation.
I agree. Any other comments on
Any sign of inflammation of the externally triggered canal or middle ear? Certainly middle ear, serous otitis media, stay away from surgery. Let them go home and come back because dead ears have been produced by the inflammatory status of the middle ear and went to the labyrinth, and labyrinthitis followed.
Sure.
I suppose an only hearing ear who has not had a trial of hearing aids, so that would, if they haven't had a trial of hearing aids and only hearing ear, it's amenable. That I wouldn't touch that ear probably, and then of course infection.
Okay, yeah, that's what we also thought. Only hearing ear. Let's just pick up on that just before we move to only hearing ear. Any other issues on the canal that somebody wants to raise? That contrary, I think we agree with that. External ear canal. Okay. Only hearing ear with the advent of cochlear implant.
Just ask a question. If somebody has exostoses, which I'm sure in Australia, some of the cold water areas, would you do the exostosis and the stapedotomy at the same time, and would you do it endorally? I would do both myself.
At the same time? Unless it's severe.
I would do both at the same time.
Yeah. I also wouldn't touch a Meniere's ear who's got classic Meniere's disease in that ear.
Okay. Let's move on to the only hearing ear. Let's hear from Marc. Marc, what do you think about that only hearing ear? What would you do?
I would personally try, like Manohar said, hearing aids, and if if it's a severe hearing loss and they're not happy with the hearing aids, have a very long discussion with them about it. And it also depends on what the pathology is in the other ear, how long they've had the hearing loss. If there's, we're now talking about cochlear implants for single-sided deafness, so it's a more complicated discussion now. You have to take the entire
patients, let's say, have been deafened in that ear for 15 years, and this has been a slowly progressive otosclerosis, and they really want something, and even though you counsel them, they say, yes, I'd like you to do the surgery. Would you still go ahead, or would you refer?
Yeah, I mean, if they understand, I will have more than one discussion. I'll have them go home, come back, and go home, and come back. And
why are you going for an otosclerotic operation in this patient? I mean, why have you considered Baha? Again, this is their only hearing ear. Why take the risk? Why not try something else first?
Well, that's what we
I
said.
don't agree. I don't.
We said we'll try hearing aids.
You count Baha.
Yeah, just everything.
But everybody would do that.
Amplification.
Everybody would do that.
Any amplification, for us, Baha is a big cost issue, so most of them won't have the money for it.
Okay.
But yes, eventually, if they want it, and this is one that I would definitely do under local.
Okay.
In only hearing here, I advise the patient for hearing aids, and he will keep this hearing aid until this hearing aid works. After that, we can discuss about the operation to increase.
So getting no more benefit from that hearing aid.
No more benefit. We try first to operate this patient to increase the possibility to wear the hearing aid, and then if the hearing aid doesn't work, means cochlear implantation.
Okay, I'm happy. Any other comments on that? We've talked about it.
This is potentially a patient that you could argue a cochlear implant, even though the ear's been deaf for 15 years and the cochlea is patent. There's no data that says a 15-year ear won't respond well to cochlear implant, and then you can do a stapedotomy on the other side once they're hearing. So, and that's brainstorming. But and if you lose their hearing, you can implant them rather quickly, and they're going to hear. So I think the stakes are a little lower, but I agree. I wouldn't jump into a stapedotomy, but I'm not afraid to do
Baha
one.
on the deafened side.
A Baha
on the deafened side, or across. Then you can do across too. Give them a single-sided deafness. Indication. Just a thought.
I probably would Baha the good side first.
Okay.
The other thing is to put a cochlear implant on the deaf ear. Is an alternative.
But there is definitely some data that the longer the period in between that the cochlear implant is less successful, and there seems to be a break point at 10 years. It's not hard data, and it's true that there are some patients that do well even after 15 years, but definitely they are less successful than you have early deafness. And that's in literature.
Good. Okay, so...
but Duane, I'd be interesting, who does single-sided stapedotomies?
Single-sided stapedotomies?
In deaf ear, on the other...
Okay, yeah. Hands up. Let's see from the audience. Who would do, if you had a single-sided deafness with an otosclerosis, who would do the surgery? Nobody?
Of course, but...
As a last resort. Yeah, no, sure. Once we've discussed everything. Okay, we've answered a couple of these. Local and general, I think everybody is day case or inpatient. Does anybody keep their patients over? Wilko.
We used to keep them 1 night, and I know Roberta's 7 nights after he does the surgery. Oh, they're going back now. But anyway, we're doing a randomized controlled trial on day case and 1 day submission, and we should be releasing these data shortly, actually. It's interesting, and I think it's pretty safe in most to do day case.
Look, we're not talking about a patient that's very dizzy. Yes.
No, you're not in a panel.
Well, it's interesting because we are all trying to find how we get better results, right? In this case, you need to take care of any items that we use. So you're saying that I've got good results. So maybe there's something also in terms of timing with the patient, following them for over the 4 days. Because you know that post-op vertigo is a problem. And with experience, the one which appears immediately after surgery is not a problem usually. But the one we have between the 3rd and the 4th or 5th day post-op is a real problem. And then it's better to get the patient with you.
And what kind of intervention?
But we don't care about that.
But
nobody cares about the items which could influence the real results.
No, very interesting to look at. But what kind of intervention do you do if they get dizziness after 5 days?
And what do you do if they call you?
We see them.
And then I already see them because they are here.
Yeah, but what do you do?
Same as you. I start
you don't
treatment.
go in.
No, I don't go in.
Okay, so
We'll come to that. Yeah, Franco?
Just, if I can spend some word for the local anesthesia, because I always done, since I was younger, only local anesthesia. For several reasons. One is a faster procedure. We don't spend time. We save operating time. And for us, with a long waiting list operating time, operate 2 or 3 more additional patients a day has got some value. The second, because the patient doesn't take risk for theoretical risk of the general associated with general anesthesia. The third, I can have a monitoring, intraoperative monitor of the vestibular function that is very important for me if I do some maneuver that can injure the vestibule during my surgery. And the last but not least, at the end, I tell some different words to the patient, different frequencies, and I have immediately the hearing test, subjective hearing test at the end of the operation. And especially if sometimes I can be not sure about the length of the piston, the anatomical situation. So at least for me, to have at the end of the operation, the subjective hearing test is of paramount importance. So I don't know.
Franco, are they under local anesthesia or sedated local anesthesia? There's a big difference. Which is it? Is it local anesthesia or sedated local anesthesia?
Local anesthesia with a very light seduction.
Seduction? That's a very good technique.
It's sedated, the patient has something else. It's very like that. There is some, probably some...
I do from time local anesthesia, but what I don't like about local anesthesia that your attention is shifted towards the patient. So instead of being busy with doing which seduction, of course, as well. If you're busy with your, if you do it in a general, you can devote your attention totally to your surgery. Where you do it in on the local, you have to talk with the patient. Of course, you're very experienced in talking and seducing, but
but everything you see, everything we've been talking about in the encampment over here is about absolute stability of the patient and no movement, nothing. And I do not believe, have you ever tried to lie still for 3/4 of an hour on a table? It's bloody difficult. Well, no, it's not true, Wilko, you know that.
And it's not comfortable for the patient. I don't think people come out of this surgery very relaxed.
Yeah, I mean,
unless they get sedation, of course.
Right, and the other thing is, I mean, I was trained in local anesthesia, but when I went to my practice, because you need the same nurse, the same anesthetist, the same, you know, if you're in a university setting, you get a different anesthesia resident every day in your room, and you have to start all over again. So that's why I personally shifted to general anesthesia, because it's safer.
You know, Marc, I've got a very nice story talking about seduction, what happened last year when Michael Glaskov was there during the course. And he's got a very funny story about local anesthesia. And the story was so funny. Then when we had the discussion, someone asked me, "Do you do local or general?" I said, "Michael, could you answer?" That is the story. You remember this one? So this guy stand up and said, "When I was doing surgery and the last time I was using on a local all the time. And one day this guy was lying down. I was doing a stapedectomy. I removed the entire stapes. And then suddenly the guy said, I want to have a pee. And I said, no, you're not going to have a pee. You're going to stay here. Oh, yes, I'm going to have a pee. No, you can't have a pee. Yes, I'm going to have a pee. And then the guy stand up and had a pee without any Stapes anymore. And then Glasscock said, that, I didn't tell. I said, that was my last experience with local anesthesia in Stapes.
You know, just a quickie on that, and particularly in a university environment. So we actually studied this, and we had more patients move on the operating table under general anesthetic than under a local with sedation. And it requires your anesthesiologist to be paying attention all the time. But the other thing, you know, getting into what Robert's bringing is, in the United States, there has been a rash of people in plastic surgery clinics and dental offices molesting women under sedated light anesthetics. And this is a very serious issue where women have woken up and they've been raped. And so when I put a patient to sleep, before they get their sedation, I say, I will be leaning on your left side or your right side. If there's any problem with that, just let us know. And so we've had the conversation ahead of time, because you're leaning on their chest, you're leaning on their breast. If there's a problem, I mean, I'm not looking under the drape when I put my hands down. And so I think that, you know, we need to be very careful about that. And there have been a lot of very good surgeons who have been treated inappropriately because of that. So these people are in an unusual plane of anesthetic. It's a dissociative anesthetic when you use sedation. And you have to be very, very careful about that.
Well, I think one thing you have to keep in mind also is that you should do what you do every day, because if you do general every day and you choose to do a local, everybody's thrown off. And actually you think you're doing the patient a favor, but you're not, because nobody's oriented, everything's different. And if you do local every day and you do general, then everything's thrown off. So if I'm going to do a difficult case, I would just do the way you always do it, because then everybody's on the same page and you're in your routine. And you're not changing for that one case.
Okay, we're going to move on, because you guys are great, but you could spend a day just talking about one question. It's interesting. So any particular post-op instructions about exercise? When are your patients allowed to have sex after stapedectomy? This is a serious question. I mean, obviously, with Doug, it's actually on the table.
Sex on the table, I never discussed.
No, but I mean, they ask about exercise, don't they? So when do they go back to the gym? When do they go running? When do they?
I normally would say a month.
A month.
Taking it easy, and
okay,
and then go fully at it.
Okay, fine. Okay. Okay. So when is it safe to?
Robert, it's mostly women that you operate, and they can.
So when is it safe to fly after surgery? Like,
the real question they ask is, when can I go to the gym?
My recommendation, physical exercise, it depends on the type. If running, just 1 week.
1 week for running?
1 week running. For severe exercise, I don't know, this kind of sport, football, 20 days, and 20 days also swim. Okay. And about the fly, I very often operate patients, as probably here in the Causse clinic, coming far away. People coming from outside Italy or from the south of Italy, like the island, Sicily or Sardinia Island. I don't know if you agree, but I ask the patient to stay around in the hotel around the hospital for 2 nights, and then they can fly back home.
2 nights?
Maximum 3 days after they can fly.
3 days. Okay.
Yeah,
okay.
Same.
So 2 or 3 days. Good.
Pretty much same.
Okay. Any particular advice on per-operative medication? Does anybody add anything special into the mix?
They all have steroids by my anaesthetist, and they all have one shot augmentin.
Okay. Anybody not use steroids per-operatively?
We don't do it routinely, but in difficult cases, elderly patients with cochlear otosclerosis and antibiotics, it was proven, well, we did a study double-blind showing there was no difference. So we don't do it anymore.
So you don't do it?
No, antibiotics. I actually give them intratympanic steroids before I go scrub as well. So I give them intratympanic steroids, plus I get IV steroids, then I go scrub.
So you actually do per... Yeah. You put an injection through the drum. Why don't you wait till you lift the drum up?
Because it's time to absorb, because around window it's going to take 20 30 minutes supraclavicular.
And is there any evidence that makes any difference, or it just feels good?
Well, in animal models, the acoustic trauma, preoperative dosing is much more protective than dosing after the insult.
I mean, have you actually seen high frequencies improve in your practice with that, do you think? Or?
I don't know. I haven't. Yeah, it's very hard to know. But based on the animal data, I thought seemed like a reasonable idea.
It seems like a good idea. I just wondered if you've seen any benefit. It's certainly interesting.
I don't know. I can't honestly answer.
Next year, you tell us.
Okay, so the golden question: which piston do we use? Let's just go quickly around. Wilko, the best one. Okay, good. Which one's that?
The upper right one, if that's a cause, we use that, and we use the one. The big easy, we don't, or I'm not sure.
Big easy,
not
no.
big easy.
Okay, so when you say we use this, are you using more than one?
We use, yeah.
Just you doing a series of 3 different?
Actually 2, and now currently 3 doctors doing a series, and we do about 90 a year or so.
So what would make you decide if you, as the surgeon, would this time use a Causse piston and that time use a Wengen?
To be honest, I like the K piston because it gets me in the flow and it works well, etc. I know Rinsi Tange uses a lot of the Ghost piston at the moment. Okay. Yeah, well, I'm happy with that because it's cheap is not the right word. It's more economic.
Like which piston do you use?
I actually use the 90 bond.
Okay.
And that's I use the
new 90 bond. Sorry, the new 90 bond with new. In South Africa, it's new with the 3 little clover looking. Okay.
I use the cheapest available in Italy. Made in Italy has its platinum Teflon piston because it's the cheapest available.
Is it a ribbon or a wire?
No, with the wire.
With the wire.
Very wire.
Okay.
I actually use the Shake Up Teflon piston, prosthesis. It's a 0.8 diameter, and there's no crimping on the Incus. Occasionally, if I have a narrow oval window, instead of drilling, I switch to the Robinson Cup, which is a 0.4. Okay. But my go-to is the bigger piston.
Have you seen with your 0.8 that you find your high frequencies or your low frequencies are suddenly better than when you used a 0.6? I know that was a discussion earlier.
I honestly don't have the numbers to tell you, but I've been very happy with it. Pretty good results of overclosure in general.
Okay. Manohar?
I use the Big Easy for Medtronics. No particular reason, just easy to put in and had good results.
Right.
Causse piston. Can I come back?
Very good. Wilko always criticises me for not having figures, and I can tell you one Shuknik piston, 70% large loop costs, 30% bucket handle. And the other reason for that is in the UK there's a big problem with MRI scanning is the MRI technicians are paranoid about anything that isn't plastic in the ear. And I know for the rest of those patients' life I can tell them I've put Teflon in and they can have a scan without having to have a certificate off me.
Can we ask that do you have any fear at all of a patient with a stainless steel piston would have a problem in an MRI scanner? Because no, I didn't ask you that.
Oh, yeah.
I said, so let's just say you get a patient and you know there's a stainless steel piston. Does that preclude them from having an MRI scan?
I think it depends on the brand. What brand are you referring to?
Yeah, I mean, I think, there's no real evidence it does make a difference, I don't think. What do you all feel about that?
I was an expert witness in a case of an MRI scan with a stainless steel piston, and the patient claimed heating in their ear at normal thresholds, and the surgeon lost.
Surgeon lost.
So there's not a radiologist in the United States that'll MRI scan a stainless steel piston.
Okay. But titanium, everyone's fine with.
Titanium's fine.
It wasn't bad, as you know.
Now, I just want to ask you, we've been talking a lot about measuring. And one of the things that gets me about measuring is it depends what piston you measure. So we saw Robert measuring from the undersurface of his incus down to the old footplate. And then he put his piston in a cutting block that comes to here, and he chopped it. And there's this extra bit of Teflon here, which is 0.5 millimeter. Now, if you do the same with a stainless steel wire, you don't have that 0.5 millimeter. So the Teflon measurement is quite different. You're basically putting in an extra 0.5 millimeter. So when John says he measures exactly to the surface of the perilymph, you then add a 0.5 millimeter, and that's why it goes into the hole. So I think it's very interesting when we compare our 4.5 millimeter that everyone seems to use. It's different if you're using that. Now, the cutting block I use is Bill Moretz's cutting block, which is actually recessed 0.5 millimeter. So you actually get the exact length. So my 4.5 is not the same as Rob's 4.5. So interesting. Oh, the prosthesis, sorry.
4.5.
Yeah, 4.5. But it's a shorter 4.5 than it. Yeah.
It's 4.5, but in the block it measures 4.25.
Yeah. Okay. All right. Just next one,
Chris. One quick stop, because for the audience, it's important to explain that you have to really know which piston you're using and how the company measures that length.
Yeah, exactly.
And then how you're measuring and account for a certain distance that goes into the vestibule. Otherwise, you're going to have the
that's right. If you're picking it off the shelf that's already pre-cut, if it's titanium and you're not cutting it, is that measurement from the base of the hoop to the bottom, or is it from the middle? And are you measuring from the middle? So you need to think carefully about that. Okay.
We're going to take up on this case. This is just because of what was discussed and what Thomas said about flying. So this was a patient in 2006. You can see the airborne gap on the left. I'm just going to run through this, otherwise we're going to go. She had surgery. That was a nice result. And then saw me about 2 months ago after flying on a plane. Oh, it's not 4th of June. It's even sooner than that, 2 weeks ago. And we've got that on the left-hand side. And that is a correct airborne gap. It's not a false, that's not a dead ear. So what's your take on that? And it was after landing. I haven't put up the other stuff underneath. I've just left it like that.
Vertigo?
Well, no vertigo. No vertigo. She just said I landed with the plane, felt blocked. Next day, hearing really reduced.
That's a huge gap. That's
a huge gap.
That's bigger than you get with a complete.
So do you believe the audiogram?
No.
Everybody agreed.
But she's probably got a hemotympanum as well.
What did I did not believe the audiogram. I believed she got a dead ear. Yeah. Tuning fork Weber's to the left. C1 to C3 Rene negative, and I'm going to quickly show you the video. So this is something I didn't believe in myself. That's why I'm showing you this. Oh wait, hang on.
Dislocated.
Okay, we'll let the master of. Sorry, I'll explain in my talk tomorrow. We now need to do endoscopic surgery because the microscopes, we have a problem in the public sector. So I was showing a resident this, and so I was having to do it with an endoscope just to show him. Because they don't have microscopes at the moment. We're battling a little bit. So this is just an endoscopic view. Sorry, it takes a little bit of a while. We're a little bit slower in South Africa. We don't have. So you can actually see the piston behind the incus there. I don't know if you can see it there. So it's a mobile. There's no erosion of that incus. Malleus is still mobile. Incus is mobile. And sorry, man, it's a little bit of a slow one. Let me just. It'll go quickly. You can actually see the piston is actually it's moving actually nicely in the round window. I then, without removing it from the foot plate, rotated it, there you can see, and put it back on the incus. And it was a Richards piston, so it's not self-crimping. We crimped it. And then I used a little bit of Thomas magic, and I put some ketochem cement just to make sure. This is just, didn't want to do it again. Okay, so. No, fair enough. No, we're not here to talk about my technique. We're talking about, is that possible? And Rob says it is possible to get that kind of airborne gap. I've never seen such an airborne gap like that.
I just saw exactly the same case about a week and a half ago. Like that same airborne gap. After flying.
She flew from Canada to South Africa.
And she was at 90. And she just came back from flying. She's actually a wife of one of the big orthopedic surgeons in our hospital.
Sure.
And exact same case. Weird.
Okay. Yes?
In my experience, there is no specific correlation between the importance of the airborne gap and the problem that we find. Sometimes we have obliterative otosclerosis and we have not a very big airborne gap, and sometimes we have things like this with a big airborne gap. So it's pretty interesting to see that. So the problem is that we have an airborne gap, so you have to do surgery, and I've seen that with just a small thing. But it's like removing entirely the third ossicle. So you can understand that you can have a large airborne gap like this.
How do you deal with eroded? Because, what's your take on this? We know yours, Thomas. You use cement.
Hydroxyapatite.
Maybe not the same thing. So something like this, you know, it's loose. They've got a conductive hearing loss. What would you do with that then, Wilko? Microphone? Can you give just Marc?
I think erosion.
No, they may not be.
Erosion is mechanical, and necrosis would be a vascular issue. And I think that there is definitely a difference in literature when they describe it. So, Robert, I'll tell you over dinner. If I'd be tempted to put a clipped piston on this.
So you just put it slightly higher up, or
yeah.
even just there, but
Yeah.
it'll just be a bit
Yeah.
tighter.
Although it's quite thicker. Yeah.
Do you worry if the end of this is already whatever it happens, say, or necrosed, that if you put a clip here that it'll just fall off again a few years down the line?
I think the only risk which has happened is that it slides off.
You worry about it
But
sliding?
I never seen continuous erosion along the shaft.
Okay, so you've not done it and it's come further back.
So I think it's more likely a vascular thing than a mechanical thing. But we also see mechanical things where you see erosion just around the wire.
Yep. Okay.
I've had some of these where I only had Serena Sem, I didn't have Otomimics, and I've been maybe put another piston or maybe balanced a bucket handle and put some Serena Sem on, and I've done 2 actually in the last few months where I've been back in where it's come off. So I'm not impressed by cement, but then I haven't got Otomimics. So I then do a
Franco.
We have no cement in my hospital.
No.
If I have necrosis, depends of the entity of the necrosis. Is it possible I crimp again the prosthesis more proximal?
Yep.
But without illusion, because very often we overestimate if this necrosis, underestimate this necrosis. And to tell the truth, when they have some doubt, I do malleus tapedotomy. I remove the ink, do malleus tapedotomy. But today I see for the first time a very interesting.
So this is a malleus tapedotomy, but you know, which we talked quite a bit. I use a measuring rod. It's slightly difficult, but precisely and accurately. Yeah. And I think that works well. But we did talk about this a little bit earlier on. So we're going to come to our last case. We talked about airline pilots, so this is an airline pilot. Just for your information, the ONDB, the way I've got it set up, it insists that I put bone conduction at 250 and 8K, so it's not part of my analysis results. That's why you have these sort of spurious results down here. So you just ignore the ones either side. But airline pilot with pretty good history of otosclerosis, or suggestive of otosclerosis. And this is what we find. So I take off the Stapes superstructure and he's got complete obliteration. So what's your take on obliterative otosclerosis in a British Airways airline pilot? Or does it make no difference? What do you do with obliterative otosclerosis?
Well, you know by CT scan that it's an obliterative.
Well, this guy didn't have a CT scan.
I program it with the skeeter because the laser will take too long time. But in musicians, in pilots, in lawyers, I'm extremely careful with Stapes surgery, because those people are the first ones who will sue you in case of problems. I've been an expert in a case where one ear was operated first with success by an expert ear surgeon, and he operated the second ear, but didn't give all the explanation, and he got a dead ear on the second ear. And the pilot sued the surgeon, saying he hasn't. Why? Because there are economical reasons why he sued him, because he lost his job. So this cost his and his family a lot of money. And he.
Well, I work near Heathrow, so I get loads of pilots. And
this pilot doesn't want Bahar or anything. And what's the rule about?
So here's a vein graft. I get the guy who does the CAA, David Jonathan, sends them to me. So I get lots of pilots. Okay. Franco, what do you do for obliterative?
Yeah, in this case, I will ask for a skeeter, a micro drill.
Yep. Okay. So basically, I just did the normal sort of. Well, I did sort of laser skeeter, plenty of time. I just worked my way through it. Yeah. Cooling. So you give it time to cool. And just work your way slowly through. But I'll just sort of. But they can take a long time, and eventually you do get down. And then I just put a vein graft and a standard piston, and that's him post-op 1 month. So left ear. Now these are the pre-ops, so it's dark blue. So he's sort of reasonably happy with that. I wasn't very happy, but he was reasonably happy. But just out of interest, that was him at 3 months. Okay, and then that was him at 2 years. So I think with some of these where with the soft tissue, particularly with the vein graft, I think sometimes they do improve a bit over time. So if you don't get a great result in a month, as long as there's some benefit, don't get too excited or worried about it. I think.
So Chris, I think a key to that case, though, is that was oval window obliterated multiple sclerosis. The round window was healthy.
Yeah, exactly.
I think the real decision making is when the round window is obliterated as well, and the data for that is poor.
Okay, so
we're
we're just.
asking if you're going to do the second side.
I've done the second side. I did it last week.
Yeah, sorry. Concerning special patients, I fully agree with Thomas, because I would like to tell you a really unpleasant story that I had with a singer in the opera, with a soprano. Even if I did a really appropriate counseling, considering of this very special patient, and I did a very successful operation. She recovered she closed the gap completely. I was really enthusiastic because she almost famous soprano in Italy. So finally she closed the gap, and when they arrived at the follow-up, I was very satisfied about. But she cried. She was desperate because she didn't recognize her own voice. She didn't recognize the orchestra during the opera. She came to me crying, no, but you are now you have normal hearing. No, but now I cannot recognize my voice. Please remove the prosthesis. And she also went to the lawyer, and the lawyer sent me a letter, but of course with the normal hearing, nothing to claim, but just an advice, please pay attention, special attention toward this very special
I think a lot of those, but they need time actually, because a lot of your patients, when you take the pack out, they say, oh, it's very tinny, it's very loud, and particularly musicians will I see lots of musicians, they complain of distortion, but over time it often gets better, I think.
But the people very involved in listening, they do seem to complain, like we did the study, it doesn't restore the natural hearing that they had. So apart from the tone audiogram, they do have a different sensation of sound sometimes. I know Robert did the same questionnaires and he didn't have it. But my patients...
No, I think...
That's because Robert measures and he uses the vague.
Yeah, exactly. That's a good point. He'll come back again. No, I understand, Franco. But the point is that we need to pay attention to pay attention in the same way to all patients. Because if we start making a difference for the decision of surgery between the type of people in terms of social or orientation or things like this, I understand, but I think we should not do that. Otherwise, we start changing our concept of making a diagnosis. You made the right diagnosis. You made the right decision because she came to see you, which means that she was suffering for the hearing loss before, and you operated on her. I mean, we all have this kind of situation which are difficult. But I don't think we need to pay attention differently because we started doing something different. Yeah, but the pilot, Thomas, the pilot, if you don't operate the pilot, he's going to lose his license also. So you have to do something.
Maybe not, but I think with the opera singer, you need to tell them that they may get some distortion of their sensation of their own voice.
Actually, you know, I live in Seattle, you know, Pearl Jam and all these rock bands are rolling out of there. So about every other person on the street's a musician. And I've had a very similar case. And, you know, these musicians' earplugs that they all wear now when they're performing can be programmed to shut everything out. And we've had a couple people that we put musicians' earplugs in, and over a 6-month time interval, they've dialed them up louder and louder and louder. And that same person who's complaining immediately in 9 months might be very thankful if you give them time, because it is a big adjustment if you've had a hearing loss for a long time. And the other thing that I've learned the hard way is they're musicians for a reason. They hear differently. And so when someone tells me they're a musician, I say, you know, you may be uncomfortable for a while. And my craziest story was a piccolo player from the Seattle Symphony who had desation tube issues after a flight. So I put a tympanostomy tube, a grommet tube in her ear, and she started missing all of her notes in the symphony. So I had to take her ear tube out. And that's a 1 millimeter diameter grommet tube, but it definitely changed how she heard. So that they kind of hear like dogs, you know, they hear at high frequencies, and so we don't really know. But I think, you know, an earplug was very helpful in a couple of situations we've had.
Going to wrap that up. It's been I'm leaving tonight, so I'm not with you guys tomorrow, but it's been a great 2 days. It's always a fantastic course. I've thoroughly enjoyed it. I hope you've enjoyed the discussions, and I'm sure you get lots of chances to ask some more questions tonight, informally, and tomorrow. Thanks.
Just before we leave, I would like to thank very much Marion. Can you show you, please? Because Marion did all the translation by herself. Without anybody... I know it's a really hard job, so thank you very much. And Chris, thank you for